Thank you all for joining us this evening as we present the webinar, COVID-19 Care, Avoid Burnout and Build Resilience, or the frameworks and an innovative initiative to advance well-being during and after the pandemic. My name is Cindy Pankella, and I am the Senior Director of the Physician Services Department at the American Osteopathic Association. Before we get started with our presentation, I'm just going to go over a little bit of some housekeeping. So next slide, please. So currently, all of the attendees are muted. You will remain this way throughout the presentation. Should you have a question, please type it into the Q&A box, and following the presentation, we will answer your questions. If you do have technical difficulties of any kind, you can type it into the chat box and I will try to respond and be able to help and work you through whatever issues you may be having. Slides and a recording of this presentation will be available on the AOA website, hopefully by tomorrow, but again, you know, that varies on other things, but it will be available. And then one of the most important things, those of you to obtain your CME credit for this, you must go back to the AOA Online Learning platform and take the post-evaluation following this webinar. It will be available to you, but you want to make sure to do that to get your CME credit. And next slide. And then just a minor disclaimer, basically saying that, you know, this is all provided as educational and is not to be construed as any sort of legal or consulting opinion, and that the information presented was current as the date the lecture began. Next slide. And we will go to the frameworks and an innovative initiative to advance well-being during and after the pandemic. Our speaker today is Dr. Gaurav Agarwal, who is a board-certified psychiatrist with special interest in mood disorders, ADHD, schizophrenia, addiction, positive psychiatry, and healthcare professional wellness. Currently, he is an instructor in both the departments of medical education and psychiatry at Northwestern's Feinberg School of Medicine. He serves as the director of undergraduate medical education and psychiatry for the Department of Psychiatry and Behavioral Sciences. He has been published in peer-reviewed journals and presented national workshops on issues of physician and medical student burnout, resilience, engagement, and professionalism. And we are very pleased to have him join us. Dr. Agarwal?
Thank you very much for having me. I just wanted to begin by thanking everyone in the audience for the role you've played in the last several months as we've responded to the pandemic. As a director of physician well-being at Northwestern, I have the opportunity to speak to lots of our docs, and I know that no matter your specialty, everyone's been doing their part and making sacrifices to defeat this virus. I'm so proud to be your colleague and grateful for the way you've represented the House of Medicine in the service of our communities. Today, I've been asked to speak about some frameworks that people can use to organize their thinking and take action to advance clinician well-being. I'm guessing many of you heard about personal resilience activities you can do, but today I'm going to speak about how to think about the system and organizational drivers of burnout. I think burnout's a pretty complex phenomenon that has no silver bullet, one-size-fits-all solution. And so I find having frameworks to guide you and apply the data about your unique situation is the most helpful thing I can share. I've also been asked to share the initiative we implemented at Northwestern here in Chicago that's allowed us to empower and engage physicians to be active participants in improving the systems we work in. I did want to tell you a little bit about the lens through which I think about well-being and what sorts of experiences have informed my opinions. I'm an occupational and organizational psychiatrist, which basically means I'm interested in workplace mental health, the role that workers and workplaces can play together to achieve optimal functioning. I've been impacted personally by burnout numerous times in my training and in my career. I've had close friends and family leave clinical medicine in their early 30s who I thought were going to be phenomenal doctors. And I know they could have been phenomenal doctors. And I felt that was a real loss for our field. But I think probably the thing that's played the most importance in my life is I have the opportunity to evaluate clinicians, doctors, pharmacists, nurses from around the country, usually around something that's causing issues with their work. Oftentimes it can be things like substance abuse, disruptive behavior, cognitive issues, etc. And when I meet these doctors, and at this point I've probably seen about 1,000 people from around the country, I often try to reverse engineer their stories and figure out, how did we get here? I don't imagine you went to med school thinking this was going to be something you ever had to do in terms of talking with me. And over time, as I would reverse engineer their stories, upstream of the issues that led them to have to see me, I would often hear the familiar refrain of things around dissatisfaction at work and burnout. And I started saying, this is having a huge impact on people's lives and careers. What can I do to not just evaluate and rehabilitate, but what can I do upstream to prevent these issues from causing issues to my colleagues? And I thought that this common issue that kept coming up around burnout and well-being and satisfaction with their career might be a place to intervene. So as you can tell, for me, the lens that I come at this work from is, I think this is a moral thing to do. I think this is the right thing to do. But I also think it's important for us to recognize that there's other cases to be made for why clinician well-being matters. And one of the major reasons at an organizational level, I think people need to be taking clinician well-being seriously is that most organizations are charged with accomplishing the triple aim, which is improve patient care, lowering costs, and achieving better outcomes for patients. And certainly at Northwestern, our motto, our slogan is patients first. And what we know is for us to be able to achieve patients first and to achieve the triple aim has to be expanded to the quadruple aim. And clinician well-being has to be a part of the equation. And so for us, when I'm working as an organizational consultant, I'm also thinking about wellness from a performance aspect, from a patient care aspect, patient quality, safety, risk aspect. And I think that's really important for us to know and for us to share with our organizations. One of the first frameworks I wanted to present to you tonight is an occupational health prevention model. And basically it looks at primary prevention where we can solve issues around how we work so that people don't experience symptoms or have disorders. And most of my work around well-being, frankly, has always been around primary prevention. How can we fix the system so that doctors can do what they're called to do, is take great care of patients? However, the pandemic has caused us to expand our scope as we think about clinician well-being to really consider secondary prevention. How do we deal with the distress and stress that clinicians are experiencing currently, and even be aware of tertiary prevention in terms of helping physicians that may actually develop illnesses, make sure they get high quality care they need so that they can be functioning, return to functioning as quickly as possible. I think one way to think about the pandemic and have a little bit of predictability, which for my well-being is very important. If I can kind of understand what's going on and don't feel lost, I tend to do better. And so I think this graph from SAMHSA really highlights a useful way of thinking about the stages of the pandemic and disaster relief. And, a caveat here is these stages were kind of designed and seen post events like 9/11 or Katrina, where there's a singular impact event, and then there's the recovery from that. As you all know at this point, that is a little different than the pandemic, which is much more of a marathon than a sprint. But what I've seen is a lot of the stages, continue to hold true. And so I think it can provide an illustration on where well-being roles can be very important here. So if you look at this model, After impact, initially there's actually this heroic honeymoon phase where the community comes together, the adrenaline is pumping, we have a clear mission and purpose that we need to defeat this virus, we come together, and actually we emotionally, a lot of people actually improve and feel like they're doing fine. And then over time, what happens is you get into this disillusionment phase where some of, for instance, the media can move on, and some of the heroic stuff from the community they're no longer thinking about us. We can have fraying of the typical areas of society where we have the us versus them mentality. We can have people run out of resources, etc., and can lead to this decline in our emotional well-being. And then slowly over time, you can have reconstruction. And it's important to recognize that there will be fits and starts in terms of the emotional phases. There'll be setbacks, there'll be potentially the anniversary reactions, but slowly but surely we achieve a new normal. From a clinician well-being perspective, I see that we have two major purposes at different areas of these phases. In the first half of the phases, I think our role is really about doing everything we can to minimize the depth and duration of disillusionment, right? None of these things are gospel. It doesn't have to be this way. And so the idea is for us to continue to provide that community support, continue to have a sense that we're all in this together and provide people with the things that they need so that we can kind of decrease that disillusionment phase and in terms of the term, flatten the curve, so that most people have minimal distress symptoms and can come out the other side unharmed. In the latter half of the disaster phases, the idea is that there will be some people that have lasting impact from all the things that they have gone through, the stress that they've gone under. And it's really important that for us to make sure that we identify those individuals and make sure that we assist them in having access to care so that they can recover as soon as possible. Now, the issue, of course, is that even pre-pandemic, the mental health system in this country was not great. And so that's why it's so important from a clinician well-being perspective to address these, the first half of the phase, to flatten the curve so that we can preserve the resources that we do have to make sure that the people that need care get it. I did want to go through some of the data that shows, what are we seeing really around some of these emotional phases that are predicted by that model. And obviously good data in the midst of a pandemic can be difficult to find at times, but I do think it's important to see what's out there. This is from the CDC. It's a pulse survey of tens of thousands of individuals. This graph shows how many, what percent of individuals screened positive for anxiety symptoms and depressive symptoms. You'll notice I don't say disorder actually. This is just a screen for positive symptoms of anxiety and depression. And I'll speak a little bit more to why I think that's really important moving forward. Having said that, you can see about 40% from April to July now are reporting screening positive on symptoms of anxiety or depression. And you can see there's a small bump from April, about 5% increase over the most recent time that we have data for. I show this graph. This is from the Kaiser Family Foundation that looked at a similar question. And I really just wanted to include this because I do think there is a clear sign that some people are starting to struggle more. As you see the pattern here, starting at about 32% of folks reporting a negative impact on their mental health, most recently in July, rising to 53%. I think this is where compassion is really important. Being aware of what other people may be going through. My sense is that the stressors are building and people are starting to think about what's going to happen in terms of schools for my kids. They are fatigued, right? The adrenaline works initially, it gets people going, but it is hard to maintain that pace over time. There's grief about losing the summer and the activities that we enjoy. There's people that are returning to work in certain areas and the anxiety that goes along with that. And so there's lots of unique stressors that different individuals are experiencing. And it's important for us to be aware of our own and also our peers as we can provide some of the most important support to each other. If we want a little bit of sense on who might most be at risk and who should we be aware of, again, the same Kaiser Family Foundation showed that in general, women have a slightly higher percent who say they've been negatively impacted on their mental health. Young folks, 18 to 29, have a significantly higher rate of negative impact compared to individuals over 65, which is interesting, of course, given the virus's impact directly is much more on people over 65. And so it highlights a little bit of a disconnect between the actual risk of the virus and the negative impact on mental health. Those things are not necessarily in alignment. And there's certainly hypotheses around both of these issues. There's some data out there that suggests that still much of the household work falls on women. And so women have been shown to be working nearly 5-6 hours more than men in terms of managing the additional housework. Both men and women are doing tons more work at home. But even after that, women were doing several hours more per week than their male counterparts. In terms of the youth, there's this thought that maybe they haven't been through as many difficult periods like the pandemic, et cetera, and so some of the resilience skills aren't there. But I also think it probably has a lot to do with the cancellation of colleges, financial prospects being hurt, et cetera. African Americans reported much more stress and negative impact than white Americans and Hispanic Americans. That particularly bumped up after the social and racial justice issues from early June. If you or your spouse has lost income, or your household is having difficulty paying your expenses, you obviously have had a higher negative impact on your mental health. Now, interestingly for us, you can notice that healthcare workers had the same level of negative impact on their mental health as folks who had spouses or themselves had lost a job or income. And so we see how we are uniquely impacted by the pandemic and need to be very cognizant of activating some of our well-being and resilience issues. A study out of JAMA showed a little bit more granular detail for healthcare workers. This is out of Italy and the experience they had. And so it showed very similar things to what we've just presented, is that younger physicians, women physicians, frontline physicians were at higher risk for mental health screenings around PTSD, anxiety, insomnia, depression, and stress. And certainly folks that had colleagues affected by the pandemic, either colleagues who died from the pandemic, been infected and hospitalized, or infected and in quarantine. So that's a very high-risk group that we want to be very proactive about reaching out to, is people that have been quarantined, been infected. If we look at previous pandemics, quarantined healthcare providers have significant residual effects. And so if we can be proactive on the front end, we can hopefully flatten that curve. What does this distress and worry look like? I think it's important sometimes to really think about, how might this be manifesting? And like I said, with my work with physicians, I sometimes know that our emotional vocabulary can be a little bit different, where we are trained to maintain our cool. And so sometimes we may not be able to use that as our guide, and understanding that some of our stress and issues may manifest in different ways can be good warning signs for us to heed. And so how are people saying they're experiencing stress? So obviously the mind-body divide is an artificial thing. There's really no difference. And so when my mind is worried, it impacts my basic human functionings, like sleeping too much or too little, eating too much or too little, difficulty controlling temper, headaches, stomach aches, increasing alcohol or drug use, and just worsening of our overall other medical conditions. 1 out of 4 folks had reported binge drinking at least once in the past week. 1 out of 5 folks had reported taking prescription drugs for non-medical reasons, and 1 out of 7 folks had reported using illicit drugs. And so again, things for us to be self-aware about, but also be on the lookout for our friends, colleagues, and loved ones. The important issue here, though, is oftentimes, again, even if you think back to the CDC graph I showed and the way that things are reported, they speak a lot about disorders. Everyone's got anxiety disorder or depression, right? That's kind of the way it's spoken about. And I just think it's really important for us to recognize the difference between disorders and things like health risk behaviors and distress reactions. So most of what we talked about just now are distress reactions, sleep difficulties, irritability, isolating, risky behaviors like alcohol, drug use, family issues or conflict. These are distress reactions and health risk behaviors. And the truth is, they are frankly normal responses to an incredibly abnormal situation. And I want to say that again, because I think a lot of times what I hear is people think, what's wrong with me? Why am I not be able to handle this? Does this mean I'm broken? Does this mean I have a mental illness? Is this mean it's never going to get better and I'm not going to be the way I used to be? And none of those things are true. And I think it's really, really important to send that message that these are distress reactions that are, again, normal reactions to a really abnormal situation, and they will improve as the situation improves and as we go through time. And I think the data suggests that when we do that, that really helps people flatten the curve, normalize the situation, and not catastrophize kind of what we're going through. And that overall can lead to this sense of resilience. I think the other thing that we can do around how do we manage stress and distress is I think when we speak about it, we can be more nuanced. My sense is that when I speak to my colleagues, and I speak to a colleague who is saying, I'm just under a tremendous amount of stress, it's hard to know where to begin for me, but also for them in terms of what can they do about it. And I think when we subdivide the generic term of stress into some of its sources, we begin to take back control of how we can address the issue. And so one framework around this comes from the stress first aid for first responders, emergency medical professionals, and firefighters. And it talks about 4 buckets that stress can come into and lead to an overall stress meter that is high. So the first one is traumatic injury or life threat. And so obviously this is the idea of being exposed to injuries or death or gruesome experiences. 2 is loss or grief. And so obviously that can be the loss of people, and we always think about grief in terms of death, but the truth is this is much more broadly thought of. This can be the loss of anything. This can be the loss of, a lot of people spoke about not being able to see their mothers on Mother's Day. Some people spoke about how they go to Disney every year and they weren't able to do that this year. Some people talk about the conferences they go to and the colleagues they meet every year and share their work with, and they weren't able to do that this year. There are lots of things that people are grieving right now in terms of their sense of normal, and all those things kind of fall under this bucket. 3 is an inner conflict or moral injury. So this idea of witnessing behaviors that violate your values. Early on in the pandemic especially, people were incredibly concerned about this, of course, in terms of ventilator allocation, PPE allocation, visitor policies, and those things still are very disturbing because we have certain values for our field, right? No one dies alone was a core value, and that didn't happen during this pandemic due to our visitor policies in a lot of locations. And so that was incredibly distressing for a lot of the docs that I worked with. And that certainly can be add to our stress meter. And then number 4 was frankly something we dealt with pre-pandemic a lot, was just this wear and tear and fatigue injury, right? The accumulation of all the different sources of stress, the long hours that we work without sufficient rest and recovery. And currently, again, the fatigue from our work is there and potentially enhanced working under masks and protective gear. But it's also, a lot of us are feeling fatigue from all the additional roles we're having to play. Caring for an elderly neighbor, being de facto teachers to our children. All of these things are adding to our overall workload and contributing to our fatigue. What I think is unique about the pandemic, or difficult about the pandemic, is generally we're getting stressed from 1 or 2 of these buckets at a time. During the pandemic, a lot of us have experienced stress from all 4 buckets at the same time, which is what's led to the stress meter for a lot of people being on the highest level. That is compounded by the fact that for a lot of us, the thing that helps bring the stress down, some of those activities are not available to us right now due to social isolation, physical distancing, etc. You know, for me in the summer, I like to go to a Cubs game, play some golf, visit certain friends, or go traveling. And most of those things that I use to bring my stress meter down aren't available to me right now. And so that's a pretty bad combination where things are being added to my meter and I'm having more difficulty removing things from my meter. I am a silver lining person. And so for me, the silver lining of this framework, though, is as far as I know, our brains are not able to tell the difference between where the stress is coming from, right? The brain just cares about the overall stress meter. It doesn't have a sense that, hey, this is coming from this bucket. And so when I'm working with people or even thinking about myself, there are usually certain buckets where the truth is I can't do anything about them, right? So for instance, if the visitor policy is a real moral injury to you, it's unlikely you're going to be able to change much about that. And so here, what we're going to have to do is look at a different bucket where things are potentially in your circle of control and you have more influence over what you can do about them and work solely in that bucket. And that to me is the utility of this model. Is a lot of times when I be having conversations with people, they say, you know, the moral injury is the biggest thing. I can't change the visitor policy. There's nothing I can do. And that's where we would start opening up different options by opening up different buckets of stress. Once you've kind of assessed your stress meter, figured out where the sources of stress are, I think having a shared non-stigmatizing language can be very useful in terms of talking about how you're doing. Again, it's to me really important not to pathologize normal reactions. And so this idea of how are you doing right now? Where are you living right now is really important. And so if you are hanging out in green, ready, healthy, well fit, that's fantastic. But I don't know most people that are in the green right now. Most people I know are hanging out in yellow. They're drained, they're irritable, they're anxious, they're sore. And what I say to people is that's okay. That's to be expected given the circumstances we're in right now. To be in yellow is totally understood. The issue, of course, is that the further you are right, the more risk you have into getting into the orange or red zones. And so if we're hanging out in yellow, we need to make sure and redouble our efforts to add things that can increase our resilience, push us back towards green as far as we can go so that we don't get pushed into the orange or the red. Conversely, if you're already in the orange and the red, orange especially is the time to really seek out professional help or additional sources of help like we'll talk about so that we can get pushed back into the yellow and get far away from the red. I think the other thing I like about this framework and model is it helps explain things to certain folks. I've got certain doctors who say, you know, I've never had any issues. I've never really been anxious, never really had trouble with my sleep. I don't really know what's going on right now. I'm always kind of in the green. And so this model kind of speaks to that, is there are certain toxic stressors, there's certain toxic levels of stress that can cause us to kind of script right from green to orange. And so when I speak to those doctors, that's kind of how I use this model and speak to that. There's certain times where we can skip right past yellow and go to orange, and now we have to really be very proactive about helping to move you back into the yellow and the green zones. The other way we can begin to help people move back and address their stress or provide stress first aid is this concept called the Hopeful Five, and it's kind of an evidence-based framework on what we do around returning a sense of normalcy after kind of a disaster or a pandemic type event. And so there's kind of 5 components on what we can do around stress first aid. First, we try to help people return a sense of safety. And so by that, we mean kind of both physical and psychological safety. So certainly thinking about physically, making sure we're providing our healthcare providers adequate PPE, having safety checks for patients, et cetera, and allowing us to feel physically safe. And psychologically, we need to make sure that we're listening to our doctors and making sure that people have a voice in terms of how they're going to return to work, and have a voice about, are they noticing things that are putting them at risk or putting their colleagues at risk, and have a mechanism to be able to hear that. 2 is calm. And so the idea is, again, that adrenaline is a good thing early, but our brains aren't designed to just be constantly on fire. And so we do have to figure out a way to calm our brains down so that we can get sleep, so we can relax, so we can get off and not be on edge all the time. And as I mentioned earlier, a lot of us have ways that we know how to calm ourselves, but unfortunately, some of those tried and true methods may not be available to you right now. And so while at other times in your life, you may not have been interested in things like mindfulness, meditation, yoga, etc., it may be one of the things that's available to you now, and a chance to try something new, given your tried and true methods aren't available to you potentially. 3 is connectedness. So again, what leads to that heroic honeymoon phase is this social cohesion, recognizing that we are in this together and that we're going to make it through this together. An important thing to think about from a connectedness standpoint is we're at the stage during the disaster where there's oftentimes a couple of people that are really good at this, that are the leaders of organizing the Zoom call or organizing kind of the lunch water cooler chat. A lot of times those people are exhausted now. They've been doing that, they've been taking the lead on that. And so it's something to be mindful of. And if you haven't been that person, consider taking a little bit of weight off of those colleagues that are those people that have been instrumental in maintaining the connectedness. Give them a little bit of break, let them recharge. But we do need to make sure that people stay connected. That's the single biggest thing we can do to minimize that disillusionment phase that we spoke about. I'm going to skip to self and community effectiveness. This is, again, the idea that we can make a difference, right? That we are making a difference around with our patients, that we have the ability to work together, and I have the ability to work together to get through this. A big part of what we can do around here is go back to times that we've been stressed or we have faced a big challenge, and remember what you did. What were the strengths you utilized? And how did you get through that very difficult time that at that time you also weren't sure you were going to be able to make it through, and figure out how you can apply some of those strengths to the current situation. And then finally is hope. And obviously hope is probably one of the best predictors in terms of achieving post-traumatic growth, not post-traumatic disorder, but actually coming out better on the other end. And that's what that's really speaking to here is, can we find the silver lining in this, both personally and professionally? And so for me as a psychiatrist, again, as I mentioned, the mental health system was totally broken, frankly, pre-pandemic. And one of the things that I think about that helps me kind of make meaning or find silver linings right now is there's a real chance that we come out of this with a much better mental health care system that is doing telehealth and providing health to communities that haven't had a psychiatrist or a therapist within 5 hours of some different communities, because we are going to be expanding the work we do with tele and digital health. And so those types of things are true in my personal life as well. Just thinking about how I spend my time with my family is different and slower. And we're using those old things like playing cards and doing board games and things that we hadn't done before. And how can we continue to have that be a part of our life post this time? And so just thinking about some of the good things that have happened and paying attention to those can be helpful in cultivating that hope concept. People have used that general concept of the Hopeful Five to really apply it and adapt it to healthcare professionals. And so they really came up with a similar 5 things, right? Hear me. What are healthcare professionals asking for? They want to be heard. They want their expertise to be respected and understood. And they are allowed to use that expertise to inform how they're going to practice. They want to be protected with PPE, with regulations around who can come into the hospital, how they're screened into the hospital, etc. We want to be prepared. So make sure that if we're being asked to do things that are outside our typical patterns, that there are algorithms, etc., that help train us to be able to provide that high quality care that we expect of ourselves. Support us. That's a lot about that. That has to do with compassionate care, transparent leadership, really acknowledging what we have been through, understanding our limitations, encouraging rest and relaxation. I think one of the things that we know from the literature is it is not stress that is bad. Inherently, stress can be quite good, actually. Stress is necessary for growth. But if we A, can recognize that and don't conceptualize stress as only bad, but B, stress plus rest is what equals growth. And so you may work out, but you have to rest your muscles for them to actually grow. And so really encouraging that rest is really important, as most of the docs that I talk to have kind of gotten past anxiety and are into exhaustion phases right now. And so that's a big part of what we're talking about at this time. And last is making sure that we're caring for our physicians and their families, especially the physicians that, again, need to be quarantined. How are we providing care for them? And then on your own, just recognizing that there's a continuum of care that you can seek, right? Again, everyone does not need to see a psychiatrist or a therapist. Most people are experiencing distress and stress and don't have a pathology. And so the clinical treatment top of the pyramid, we can preserve for people that are actually experiencing illness or disorder. And there's lots of other options on this pyramid, including great things around webinars, such as this, hopefully, that can provide additional information about mental health literacy, self-care, competency, leveraging people in the faith community, your primary care doctors, peer workers, crisis responders, hotlines. There are lots of additional ways that we can get care on the pyramid. For the vast majority of people, that will be perfectly sufficient in terms of flattening the curve. Now, I wanted to make sure that we address some pandemic-specific issues, because obviously I know that's what a lot of us are dealing with, but I do want to speak to a little bit about as people go back to work, as people are trying to get back to normal and reactivate, the truth is that nothing should go back to normal. Normal before the pandemic wasn't working. If we go back to the way things were, we will have lost the lesson. Maybe rise up and do better. And so that quote is really highlighting this idea of what we talked about before, is how do we make meaning of what we've been through? How do we learn something from what we're going through so that we can be better than the way it was? Because the truth is, the way it was that almost half of all physicians were burnt out, right? There's obviously wide variations amongst different specialties, but the best data we have from 2017 is half of physicians were burnt out. And that's just completely unacceptable and not a normal we want to return to. And so, how do we think about that from a framework of the system and the organization? The National Academy of Medicine came out with their system model of clinician burnout and professional well-being last October, I believe it was. And it really brought together some of the best minds from many disciplines, and really kind of came together with what's the best data show us. And their system model, I think, is really instructive for us. They basically talk about 3 different system levels that people that impact burnout and well-being. So the first is the external environment. And so that's really speaking to, there are certain things that only the healthcare industry, government regulations are responsible for. That there are drivers and issues that are at that level that it's important for us to recognize. And obviously, again, we're seeing some of those things in the pandemic in terms of the regulations around telehealth, the regulation on what needs to be included in notes, licensure issues. And so those sorts of CMS issues are only are on that level. The next level is healthcare organizations, so kind of the overall potential hospital, clinic, et cetera, that you work in. And so the management, the benefits, the pay, the leadership of that healthcare organization contributes to certain amounts of drivers. And then finally, the last system is the frontline care. That's kind of where you work day to day. What's the physical environment like? What's the workflow like? Who are the people that I'm working with? Am I provided with the things I need? And so that's kind of your individual department or area of work. Those three systems are impacted on the work system. So those are kind of the demands and the resources that are inherent in our work. And so the demands can contribute to burnout by having poor efficiency, having too much workload, having the moral distress issues that are part of it. On the other hand, resources can balance out some of those demands in terms of the community you feel with your colleagues, in terms of being able to provide care, having meaning and purpose in your work, the amount of control you feel in terms of how you work. Those are the work system factors. And then all of that gets funneled through each individual's and their kind of individual makeup, right? How do you cope? How do you, what stresses you out? What do you think about? And all three of those things interacting lead to either outcomes of clinician burnout or professional well-being and the consequences that result from those to patients, clinicians, the healthcare organization, and certainly society as a whole. And the reason I think this framework is very useful is, especially at an individual level, it helps us all kind of really focus in on what's in our control, what can I influence, and what's really out of my control. And I think as a coach, I really work with a lot of people to really highlight when we're worrying about something, what are we worrying about, and how much of that is in your control at all. And there are going to be things that are outside your control, right? No individual doctor can do very much about CMS, right? But I do have things that are within my control that can improve my fulfillment with my work. And there are things within my influence where I can help begin to cause a change. And the more time we spend in those two buckets, and the less time we focus in on the things that's out of our control, the more likely we're going to be able to advance our own well-being and advance the environment in which we work. And so, the National Academy of Medicine came out with this model. It came out with a great summary of all the literature, but the truth is it's still been really difficult to execute their recommendations to fix these systems and improve burnout. And so the question is why, and how do we respond to those barriers? And so the first part is there is a tremendous amount of literature on burnout and well-being that is important to know if you're going to make effective change. I think when I speak to a lot of physicians, a lot of times people really boil it down to something simple like, just get rid of the EMR and things will be fine, or just pay me more and it'll be fine. And all those things are fine, but for the vast majority of people, there isn't a silver bullet. And understanding that evidence base is really important in terms of being able to make effective change. Number two, whenever we talk about, for instance, physician burnout, we're always thinking about this generic physician out there that has these specific drivers of their burnout, right? So whether it's pay or malpractice suits or job security, we think about the physician in that way. But the truth is, there is no one type of physician. Each of us have our own specialties that have their own stressors. And I think, again, the National Academy of Medicine does actually a really good job highlighting that aspect, is that our work units are quite different. And so surgeons have a very different set of drivers that contribute most of their burnout compared to anesthesiologists, compared to radiologists, psychiatrists. And recognizing that uniqueness allows us to not kind of come up with this top-down, heavy-handed solutions that are designed to fit everybody, because they don't fit everybody. The other issue, of course, is that where we work matters. That these concepts are maybe more generally applicable, but how they actually manifest, how they look, depends on where you work. So for me, I work in Chicago, and but if I went to a psychiatrist even maybe 50 miles away from me, their drivers, their stressors, their local environment, their leadership, they have totally different problems than my own. And for me to tell them how to fix their problems would be quite difficult and probably foolhardy. There's also this issue of when we're working, we're not able to leverage the full organization usually, because there is this, oftentimes this culture of the white coats versus the blue suits. And what are the admin folks doing, and how are they thinking up how to ruin my life today? And on the other hand, the blue suits are like, I'm trying to help, but the white coats aren't really engaging and being a part of the solution. And so that is not leveraging all our abilities to come up with a better environment. Our goal has always been to really empower physicians to be able to make change. And what we found is you do need certain sets of skills and certain knowledge to make effective change. And a lot of that knowledge comes around how do you actually make, how do you do project management? How do you do process and quality improvement? Do you know about the science of wellness? Do you know how to drive change and manage change amongst team members, build consensus, get buy-in? Do you know how to work with your department administrators, system administrators that may have a lot of knowledge around things like EMR, for instance, so that we can all come together? And the truth was, when we surveyed our physicians, most of them weren't comfortable in these key areas that are needed to really make effective change, which kind of explained why a lot of times physicians would get really frustrated that they weren't able to change the system. And so what we did was we created this initiative called the Scholars of Wellness. And really it's a professional development program with the objective to create this critical mass of wellness leaders that could drive meaningful change. And they were, it's a year-long curriculum that our physicians are selected to be a part of, where we teach well-being science, process improvement, and change management. And when you get those three things together, you really have the chance to have a physician that can really speak to the local needs and create sustainable change. And so the idea, of course, is for this curriculum is we had two objectives. One was to develop these leaders, kind of have this critical mass that joined our physician wellbeing team. And two was to create pilot projects all over the system that could help us see how things were working on a small scale, see what we needed to implement proven things that improve wellness and are part of improving, creating a culture of health, and then learning from those pilots and potentially expanding those pilots. So we delivered this curriculum over a year. The physicians received 5% protected time to attend the lectures and work on their pilot projects. We would meet together for an hour every other week and go over some of these learning objectives and curriculum topics. Over time, we'll have trained 28 physicians representing 11 of our departments, and each of them have picked different pilots that have really expanded our notion of wellness. I think a lot of times this wellness concept has gotten a bad rap because it's supposed to be code for yoga or eating well or sleeping well, but the truth is that that's not the organizational level stuff, right? We're thinking about mentorship and onboarding and team-based care and inbox management and EMR optimization. And the more we do these pilots, we help create this shared vocabulary where people start to understand when we're talking about wellness, we're talking about how we work. And so almost anything we are doing to improve our ability to provide patient care is a wellness project, if you will. And that's been really important. Having these physicians in all these different departments allows me in my role to have somebody who I know is trained to know how we are trying to make change here and can be my partner on the ground and provide me information and initial buy-in to make effective change. And so the idea, of course, is we then identify these pilots that we think are feasible, that identify a driver on an organizational or work unit level that we want to address. We develop that pilot. For instance, the example we give here is we created a peer support program in a couple of departments in anesthesia and OBGYN around helping physicians talk to other physicians after a medical error or an adverse event. We see how that worked. What are the barriers? How do we actually do this? We scaled it to the entire hospital system. And this year we're planning on expanding it to all 10 hospitals in our system. And so that identify, develop, scale, and sustain model is what we're doing to create positive change. And what it takes is it takes a bunch of these pilots to really have a sufficient harvest to really feel it and feel the culture changing. We're doing the same thing with these scholars, these physicians that we identify as people that have a passion for this, have that servant mentality where they want things to be better for themselves and their colleagues. We develop them through this program. We identify the people that are really getting it and make sure that we put them in positions where they can be leaders in their departments, in the whole hospital around well-being, and then really be leaders to continue to advance this culture all across our system. The data shows quantitatively that after the program, people had a significant increase in the knowledge and skills that we talked about around well-being, change, and quality improvement. And I think one of the things we're most proud of is that about 60% of them agreed their burnout had decreased. And to me, that was a real wake-up call and reminder that the truth is, yes, we gave them 5% of their time, but the truth is they did way more work than that. And so in some ways, I added work to these physicians' lives. But it wasn't just about amount of work, right? It's about the meaning we have in our work and the feeling that what we're doing matters and can create change. And so despite adding work, 60% of the docs reported improvement in burnout, and no one reported increased burnout. And so that was just a big lesson that if we can continue to develop people, give them resources, create community, have them be empowered, that I do think that's really important. And 70% reported they felt more confident in recommending Northwestern as a place to work, which is a metric that I think a lot of interventions haven't been able to show. And so we're very proud of that metric as well. Qualitative data to me is always more meaningful in some ways than quantitative data. And you just hear the things that people said. It enhanced my own sense of well-being, it engaged me with my system. It made me feel like leaders wanted to listen and were interested in my solutions to solving burnout. I feel a new camaraderie with my peers, and I want to work with my administrative peers as I realize they have things, skills that they can offer that I don't have. And for me to be able to make the change I want, we're going to have to leverage each of our talents. So overall, I think it's really important to recognize that there's a journey for organizations that have to take. And a lot of times what we're doing is we're starting with awareness, we're understanding drivers, and you may not feel it right away. There might be minor or moderate feeling of the change, but that's the process you have to go through as you begin to then do some of these pilots, change some of these policies, measure burnout, and that's when you can start really seeing a transformative culture change. And for us, that's what we have seen over time is last year we were recognized as one of 22 organizations in the country that received the Joy in Medicine award from the AMA, and the Scholars of Wellness program won an Innovation for Physician Wellness award. And so we're building momentum, we're getting small wins. We have a lot of work to do, but it gives us the momentum and the critical mass of individuals that we need to be able to make change. I think Margaret Mead said it well, right? Never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has. And so for us, these 50 doctors that we are part of our team and have been trained in various ways are really the physician well-being team. I get to be the director, but really training these individuals to make the change and be our soldiers, if you will, on the ground has been all the difference. So with that, thank you, and I turn it back to you, Cindy.
Thank you very much. Okay, it's now time to type in any questions that you may have into the question box, and we will get to them shortly. I wanted to go over some resources that we have. The physician support line actually was developed by Dr. Mona Massoud, who is a DO, and it currently is being manned by volunteer psychiatrists that are free. It's offering free and confidential hotline between 8 a.m. to 3. So please take the time to contact them if you need them. It's important. We want to make sure that we keep all of our physicians healthy. And so please, if you need help, please get it. Next slide.
Just to really quickly add, I have a lot of colleagues that are psychiatrists. I'm a psychiatrist, and we have, we know people that volunteer for this line, and it has really been effective. And I know lots of physicians that have used it. It's really high quality care, and so certainly, I encourage it if you need it as well.
Okay. All right, then as in the past, our osteopathicorg COVID-19 website that is updated regularly with anything new that is going on, and that to help you so that you only have one place to look for all the information you need. Next slide. This is just some of the on-demand webinars that are available that we've put on since COVID-19. There actually is a total of 16 of them. So this is just a sampling of what you can find, and those are available on the AOA Online Learning. And these are some of the upcoming webinars. Tomorrow night, we have a practice security and staff safety that I think you'll find very informative, and maybe some things that we don't really think about as to how this is impacting some people in a violent manner, and we want to make sure that we keep the practices safe. And then we have practice reopening strategies and that'll cover some policies and procedures that you should have in place. And then we have some cybercrime and HIPAA that's been going on, all based on COVID. So those are things coming up. And then we have a reopening your medical practice that'll be coming up. We don't have a date set yet, but that will focus a little bit and incorporate how to make sure that you're doing everything to keep everybody safe, while also incorporating or using the OMT in your practice. So again, those will be available on the AOA Online Learning, and we also will, of course, advertise them and make you aware of all of those. Next slide. And then to obtain your CME credit, you need to go back to the AOA Online Learning platform, and you will have, it'll come up to this picture that you see there. Put in your username and your password to get in. If you do not have one, you are allowed to create an account there, and then you'll be able to locate the post-evaluation, which is available in the actual course for tonight's webinar. And then we will go to the Q&As of this physician services mailbox and phone number. This is how you can reach me and my team. And then let's go to the questions. So the first one that came in, what about the mental health stigma in medicine? I know many won't reach out for fear they won't be able to get license renewal. Thoughts, comments on how to work with this?
Yeah, I think that's a great question. And a big part of why I was focusing today on this difference between distress and illness is a part of how do we address this mental health stigma. Is that from a license renewal perspective, there have been people that have been working on this problem for the last several years in terms of what are the type of questions that people can ask in terms of receiving mental health care, et cetera. And I think it is important to recognize that many places have changed the types of questions they can ask in terms of being more about current symptoms and current impairment or disability versus have you ever received mental health care. And so I do think that's important to recognize that things have changed, but there is still definitely more room to go. And then the second part of that is really highlighting that if we're going to receive peer support or support around distress, there's nothing to report. When you didn't have a mental illness, you were experiencing distress and stress around a very understandable issue around either pandemic or an adverse event, et cetera, et cetera. And so really highlighting the difference between those things, I think is very, very useful. I think the other, silver lining for me is that I do see a difference happening around stigma. A lot of these things around loneliness and stress and anxiety and panic that we never used to speak about, certainly not speak about openly within medicine, are common everyday topics right now. Like everyone's talking about social isolation. They're talking about loneliness. They're talking about being stressed and overworked and tired and fatigued. And so I'm really hopeful that that is a silver lining coming out of this, is that some of the stigma is coming away as people are recognizing we're all struggling with some of these issues and that the pandemic has created.
Okay, thank you. Any other questions? I don't see anything coming into the mailbox. I do have a comment that says that great topic, thank you for the lecture. And I agree, I think it is very timely and I'm very, wish we didn't have to talk about this, but I think it's important and that nobody should be ashamed and should be willing to get the help and get the discussions going that they need to, especially because you guys are out there in the front lines taking care of all of us. So I thank you for that. Dr. Agarwal, thank you so much for this, and we appreciate it. And anyone that did not want to type in a question, if you feel that you want to send it to physician services, please do. I then in turn can connect you with Dr. Agarwal and you can, I will forward your question on to him. So that's an availability also. And as far as getting a clickable link to get credit, no, you have to go back to the AOA Online Learning platform and take the post-evaluation there. But again, thank you all very much. And this does conclude our webinar. Thank you.
Thank you.